A hearty welcome to respected seniors, colleagues, and my dear friends for today's CME on NIPS and newborn screening for genetic disorders. We all agree to the fact that prenatal testing is the best strategy for reducing the burden of genetic disorders and congenital disabilities that cause significant postnatal functional impairment. To know more about this topic, we have with us experts to share their knowledge and experiences.
So, without wasting time, we move on to our lectures. For that, I invite our today's chairpersons, Dr. Meenal Chidgupkar. She is Director of Chidgupkar Hospital, Solapur, infertility and IVF specialist at Apollo Fertility, Solapur. 12 years experience in infertility laparoscopy, diploma in infertility laparoscopy, fellowship in reproductive medicines, work extensively on adolescent health. Dr. Kundan Chopde. He is consultant pediatrician at Chopde Child Care and Chirayu Hospital, Chirayu Children's Hospital, attached to Ashwini Medical College as assistant professor, and past organizing secretary for Mahapedicon Solapur. Over to you, chairpersons. You can please start.
Good evening all. As a president of Solapur Academy of Pediatrics and on behalf of Virkar sir, I invite you all and I welcome you all for this wonderful CME on this excellent topic. Without wasting time, we will just start the CME. In the first lecture, the madam will introduce our speaker.
First lecture is by Lakshita Chauhan. She is Senior Consultant Genetic Counselor, Pathkind Diagnostic Private Limited. She is a genetic counselor by profession and currently working as consultant with the Pathkind Diagnostic Private Limited. She has an experience of more than 5 years in genetic counseling. Her major achievements: she is the first genetic counselor of Indian Armed Forces for more than 3 years till date, worked with the National Inherited Diseases Administration, Kendra, Department of Biotechnology as a first genetic counselor India, set up first genetic clinic and lab in Army Hospital Research and Referral, New Delhi with medical genetics. She is also signatory authority on genetic reports of armed forces. She is also have experience in working with fetal medicine experts, pediatricians, gynae and oncologists and IVF specialists. Her skills include counseling, genetic disorders, high-risk pregnancy, cancer genetics, pedigree analysis, genome analysis. Ms. Lakshita is having experience of more than 5 years of experience in this wonderful field of genetic counseling. Prior to joining this Pathkind Diagnostic, she worked as a senior genetic counselor, senior consultant genetic counselor, and she also runs her genetic clinic in My Gene Screen Clinic in Bathinda. In her present assignment as Pathkind Diagnostic, she is handling genetic disorders, high-risk pregnancy, cancer genetics, preconceptional, prenatal and postnatal genetic counseling, pre- and post-test counseling, communicate highly sensitive, distressing and complex findings to the patient by discussing in the implication of the test, benefits and limitations, and facilitating unbiased decision making, using a customized non-directive counseling approach to support the patient in coping with the report findings. And she worked as a part of a multidisciplinary team to resolve queries pertaining to genetic reports and provide the best class support. So I will invite Lakshita Chauhan madam. Stage is all yours.
Good evening all. Thank you so much for inviting me as a speaker here. So my name is Lakshita, and ma'am has already given us such a beautiful welcoming for me. Thank you, ma'am. So my today's topic is basically I'll be covering prenatal testing, which includes prenatal screening and prenatal diagnostic testing. So the topic for my today's presentation is integrated approach utilizing biomarkers, non-invasive prenatal screening, and prenatal diagnosis for comprehensive fetal assessments. So, as we all know, prenatal is a time, is a period before the birth. And there are three stages: trimester 1, 2, and 3. So, when we talk about trimester 1, it is 0 to 12 weeks. Trimester 2 is 13 to 24 weeks, and trimester 3 is 25 to 36 weeks. So, being a genetic counselor or being in a setup of genetics where I practice, so the most important concern for me is basically the first two trimesters where I can actually help a patient in certain manner where I can move around and I can help them. So basically, before going into the testing in detail, so I would like to just give a brief about what prenatal testing is. So basically, we provide a valuable information about the baby's health because as all the gynecologists sitting here, they know it how important each and every pregnancy is. So to understand the risk and benefits and how prenatal testing can affect the life of a newborn. So basically, prenatal testing is divided into two parts. One is the screening test, the other one is the diagnostic testing. So when I talk about screening test, it is nothing, it is just a screening. So when we go to an airport, so we are getting screened there. So every passenger that is going, they are getting screened. But then the suspected ones are the ones, those who actually carry something which is harmful to a particular individual. So in that case, so when we are suspecting something in a screening test, that is when we go for a diagnostic testing. We do not directly jump into the diagnostic testings. So when I talk about the prenatal screening, first of all, it is very easily available nowadays. Every single lab, everybody is known about what prenatal testing is. It covers the biochemical markers and also the NIPS. And diagnostic testing is basically an invasive testing, which we will discuss in detail. So basically, there are 5 types of prenatal testing. So how we have divided it: for screening, we have maternal blood serum, then prenatal ultrasounds, and non-invasive prenatal testing. So I will be briefly talking about maternal blood serums and prenatal ultrasounds, the biomarkers, and the next session is by the next session will be taken for the detail about NIPT. And also in my presentation, I will also touch the diagnostic testings. So when I talk about the diagnostic testing, so it is done by a more specialist doctors, the fetal medicine experts, those who do the certain procedures, which includes amniocentesis and chronic villi samplings, the CVS. So now if I talk about prenatal testing, so if I talk about screening, so screening has biochemical plus soft markers and invasive, non-invasive testing. And then when I talk about, so my biochemical and soft markers are further classified into twos. One is dual marker or the pentamarkers that is done in the first trimester. The other one is triple and quadruple marker that are done in the second trimester. So we will be discussing each and every markers in detail and their specificity and sensitivity. Now coming to the diagnostics, so CVS sampling, chronic villi sampling, it is done in 11 to 13 weeks, again first trimester. And amniocentesis, it is done in the second trimester, that is after 16 to up to 16 to 20 weeks, 22 weeks, it is done. So when we talk about the screening, why are we more concerned about aneuploidy screening and who are the ones who should be screened? First of all, there are certain guidelines that says that any pregnant woman that is walking inside a clinic has a right to get screened for the certain genetic disorders which are the most common. So when I talk about the certain genetic disorders which are common, like Down syndrome, which I believe everyone sitting in this faculty has seen Down syndrome at least once, not multiple times, but at least once they have seen what a Down syndrome baby look like and how the life cycle of a Down syndrome goes. So now I'll talk about the soft markers. So initially, before we order any screening test, that is the biochemical testings, we first do the ultrasound. That is the ultimate goal for everyone to look into the ultrasound and to find out is everything all right inside the womb. Because it is said that that fetus is also a patient. Fetus is not less than a patient. So the soft markers that we basically look for is knuckle translucencies, NT, cystic hygromas, nasal bone, tricuspids. These are the basic markers which we basically look into the if there is any high risk pregnancies. Now, if I talk about what this soft markers play a role when they combine with the biochemical testing. So, if I'm sent, if on the basis of that, if my patient is having uh, high NT values or absent nasal bone, so depending upon that, if I say, okay, fine, this patient looks like a Downs, this fetus look like a Downs to me. But then what is the confirmation? So to get the confirmation, I will jump to screening test. That is basically the biochemical screening in which I will be needing maternal age, what is the age of the mother, then the two markers, biochemical marker, HCG, and the other one is PAPI. So if I only have the two biochemical markers and maternal age, so basically these are the dual markers. But what is the sensitivity if alone I have these two markers? And I don't have an NT scan. My specificity and my detection rate will be 60 to 65% only. No matter what platform we are using, no matter what technique we are using, the detection rate will be 60 to 65%. But now, at what age should I give my testing? That is important. So if it is 9 to 10 weeks plus minus 6 days and I am having maternal age and both the biomarkers, my detection rate will come out to be 60 to 65%. But if the same test is done again in the same first trimester, but the timing is 11 to 13 plus 6 plus and minus 6 days, with my NT scan or my ultrasound scan, my detection rate reaches up to 90 to 91%. So when I talk about 90 to 91%, so it actually both, whether it is a soft marker or it is a biochemical marker, both holds a similar weightage. So when they club together, the detection rate automatically increases. Now coming to the early detection and early biochemistry, if we want to do the early detection. So again, both the markers with my NT scan, my NB scans, I will be reaching to a particular detection rate. So this was about the first trimester screening. That what is the importance of just NT scan when it collaborates with the biochemical markers. So soft markers and biochemical markers holds the equal role. Now coming to the second trimester screening, triple marker and quadruple marker. So triple marker, most of us are not doing triple marker, reason being it is one of the obsolete ones and the detection rate is quite less. But then quadruple marker is equally important as compared to the dual marker. So basically in quadruple marker, the difference is the marker that we are using here is alpha fetoprotein, which basically tells us about the open neural defect that is present in the fetus. There is no as such diagnostic testing if in case my ultrasound says that uh, there is a open neural defect, and in my biochemical reports also says that the alpha fetoproteins are at increased level. So then what? So if both of them says ki yes, it is at high risk, there is no particular diagnostic testing to find out that whether it is actually correct or not, because ultimately this is a screening tools. But now what do we suggest next? Because there will be multiple times we'll be seeing patients with open neural defect and coming with the positive report of quadruple markers saying that alpha fetoproteins are high. So in that case, we have to tell them that thorough ultrasound plays a very important role and the deep ultrasound plays a very important role, and that's only the reason how we can detect open neural defects. Now, coming to the first trimester again, so here I've explained how each and every marker plays a role. So, if I talk about free beta HCG, so if it is increased in a dual marker report, if the free beta HCGs are increased, it is pointing towards trisomy 21, that is Down syndrome. And if it is decreased, it is pointing towards trisomy 18. Similarly, if the PAP-A is reduced, so it is again somewhere or the other trisomy 21 or 18 is present. So now what is the duration and what we are actually looking at that we have already discussed, and who is the person who has to be tested for it? All the women, those who are expecting, are the right ones to go for this particular test. Now coming to the what is the risk assessment for first trimester screening. So when I talk about risk assessment, so if I'm getting my prenatal, if my markers report, whether it is a dual marker, quadruple marker or triple marker, if my report says it is a low risk, then the for next 7 months, 6 months, the pregnancy will be normal and we won't be worried about it, and normal routine scans will be done just to take a follow-up. Now, what if there is an intermediate risk? Now, if there is an intermediate risk, we cannot say that yes, this patient is normal and we can just follow up with an ultrasound. We have to do a deep ultrasound. We have to look for certain parameters. We need to look for nasal bones. We need to look for tricuspid flows. What is the facial angles? All these are required. And the risk is usually 1 in 50 to 1 in 1000. So basically, the intermediate risk is the risk where we miss a lot of patients. Now coming to the high risk. Now if my report says that this patient is at high risk, 1 in 50 or 1 in 100. So now for an example, a dual marker report came out positive for trisomy 21 and it says that it is at high risk and the risk is 1 in 100. So now what? Will I go back and do a quadruple marker? Will I do a NIPT? Will I do directly tell them, okay, fine, because the dual marker is positive, let's terminate it? No. So the best approach is let's not waste time because already we have diagnosed it with dual marker with the NT and NB scans. Now what we'll do is we'll directly jump to NIPS, which is a non-invasive genetic testing. So the sample will be non-invasive. It will be a maternal blood will be taken, but then out of that maternal blood, we will be extracting the DNA, cell-free fetal DNA from that. And depending upon that report, that is also a screening test. Depending upon that also, we cannot decide. But then yes, the sensitivity is 99% as compared to the dual marker or any other quadruple markers. But now what if the testing says that it is at high risk, 1 in 10? Again, do I need to wait for NIPT report? Because again, my NIPS report will take 10 days or like 15 days and will come back. So what do I do? So in that case, because it is already at high risk, very, very high risk, we'll directly go for a diagnostic testing. So now these are the markers for second trimester. So alpha fetoprotein, as I've already introduced about it, that it is basically involved for the baby's protein development, and if it is absent or it is reduced, so the condition that it directly implies is the NTD, open neural defects. So now there are certain screening tests that are done. So there are combined screenings also. So in which dual marker is the sample for dual marker is taken, the sample for quadruple marker is taken, but you will only get one report. So they will club all the results in one report and will give you the access that yes, this is at high risk or not, so that you don't have to wait for it. So again, in this also we will be needing the USG reports. And if it is just a serum report, then obviously we don't need the USG report, but again the sensitivity will come down to 60% as compared to the integrated reports. Now, I have been talking about the sensitivity, specificity, what exactly it is. So when I talk about the sensitivity, so sensitivity is basically the percentage of affected pregnancies that are being screened positive. So what is the number of pregnancies that are being screened positive from that particular test? whether it is whether it is dual marker or whether it is quadruple marker. Similarly, what is the specificity of that test, that whether it will give me a false negative report or not? What if, because it is a screening tool and it is all machinery based tool, no human is involved during the analysis or during the testing, it is all machinery based, so the chances of false positive is also high in that case. So that is why whenever we order the particular test, whether it is dual marker or quadruple marker or triple marker, if we order, we should know, the first thing we should ask is what is the sensitivity and specificity of the testing. Now, these are the most common conditions that we look into, especially when we do the screenings: Down syndrome, Edwards, Patau, and open neural defects. Now, coming to what is NIPT. So, NIPT is usually, it is again a screening tool. There are certain guidelines, especially from ACOG, American Council of Obs and Gynae, says that instead of dual and quadruple marker, you can directly jump to NIPS because the sensitivity is quite high for that. It has again pros and cons about it, which sir will be taking in detail. So, I will just give a brief about it. If a NIPT is normal, then that means you can continue with the pregnancy and no other complications, just a follow-up is done. But what if it is positive? Now, when it is positive, that is when we have to take care of what to do next. If it is positive for trisomy 21, what next? Are we going to do CVS? Are we going to do amniocentesis? And if we are going to do that, after getting that sample of amnio or CVS, what test are we going to order? So that is where the role of diagnostic testing comes. So these are the certain recommendations which says that ACOG says that clinically guidelines are there, that NIPT is recommended for all the pregnant women. So they are there. So here in Pathkind, if you send a sample to us for an NPS, so what do? We collect the sample, we register it. The thing is we do the DNA extraction, because we need to know that whether the DNA that we are testing for, is it the mother's DNA or the fetus DNA. So that is the most crucial step. So once that is done, we amplify the DNA to know what is the specificity and what is the coverage of that particular DNA. We do the analysis and then the reporting is being issued. So it approximately takes around 7 to 10 days in reporting. Now we have talked about the screening. So this was all about the screening. Now, what if the screening comes out to be positive? So there are multiple cases that we have seen where the screenings have been come out positive. So this is a chart which explain like what exactly we need to do if the serums are positives, if the biochemicals are positives, and if in case the NIPS is positive, what is the right pathway that we have to follow. So before we jump into the diagnostic testings, the right hand rule that says is never do an invasive testing or advise termination on an isolated screening results or just on the basis of soft markers, because they are just screening tools and we cannot depict that whether the fetus is actually affected or not. Now, what is the role of genetics in obs and gynaes? So, if a patient is coming with says that they have multiple abortions, what next? And when you do an anomaly scan, you find out there are multiple aneuploidies that could be seen, multiple soft markers are there, fetal anomalies. And the most important is if a couple is coming to you, because the gynaes are the first one, the patient, the mother who's carrying the baby for 9 months trusts her gynae most. So in that case, if there is a bad obstructive history or if there is a previous child who has been already affected with XYZ genetic disorder, so in that case, what? Are we directly going to do a testing on the fetus saying that, okay, the first child is already affected, or we are first going to test the child who is actually being affected? So technically, we first do the genetic testing for the child who is firstly affected, the proband, and depending upon that, we'll decide whether the test has to be done on the fetus or not. Similarly, when we talk about the multiple abortions, there are multiple tests that we offer. After doing all the immunological testing, all the biochemical testing, we offer karyotyping just to rule out if there is any balanced translocations, and then couple carrier screening if they are the carriers of any particular conditions. Now coming to the invasive testing. So, what is the need of doing invasive testing? All this while we were just discussing about the screening. So, 8 million newborns are being born with the birth defects worldwide, and 1.3 crore children are born with birth defect in India every year. And out of which 50% of them are being undiagnosed or left undiagnosed during their normal scans. So now if I talk about the first test, that is the karyotyping. So as I mentioned, if my NIPT comes out to be positive for trisomy 21, now what? We will refer the patient to a fetal medicine expert. They will take a sample, they will take a amnio sample, or they will take a amnio sample or a CVS sample. Depending upon that, depending upon the biomarkers, depending upon the ultrasound they do, and depending upon the screening reports, we will check for the particular trisomies, the commonest ones. So the best test to check for is the karyotyping. So what are the indications when do we order karyotyping? So basically trisomy 21, 18 and 13, and any sex aneuploidies if they are present, ambiguous genitalia if it is present, delayed puberty, obviously that would be the case not in the prenatal part, but then yes, if a female comes in the clinic and says that there is inappropriate secondary development, sexual development organs or delayed puberty, so in that case the first line of test would be again karyotyping. Short stature in females, again karyotyping. And if in ultrasound we find any heart related defects or cleft lip or cleft palate, so those are the ones which we will look for in karyotyping. So now when we talk about the karyotyping, so this is how a karyotyping report looks like. So this is a chromosomal place, how the chromosomes are placed. So in females it will be XX and in males it will be XY. So this report says that this is positive report for a trisomy 21 because in chromosome number 21 there is an extra chromosome. So this karyotyping is basically mapping of your chromosome structurally. So if you look a building from outside, how does it look? How many rooms does it? If there is an extra room or there is a less room, we can easily count it. It is just a mapping of your chromosomes. But then again, it also has every test has its own benefits and its own limitations. So if there will be, if in case all the chromosomes are there aligned properly, all the 40, in this case, this is a clear cut case of trisomy 21 because there is a extra copy of extra copy on chromosome number 21. But then, for example, if this is a normal report and this is all in together, there are 46 in total, and but then there is some deletions or duplications that are present. So what we will do then? So in that case, we have to order some other test which will actually look into the deeper into the chromosomes ki what exactly it is deleted or what exactly is the duplication that is happening. So in that case, we will go for the other test, that is microarray. So now coming to the test FISH. So FISH is again, initially it was used as a diagnostic testing, but again recent guideline says that FISH is also a screening test now. On the basis of FISH, we cannot say that we can terminate the pregnancy or not. So now FISH is also a screening tool. So we cannot consider it as a diagnostic testing. So it is basically a probe-based test in which a cell has to grow, and depending upon that, the probes get attached to a particular regions. So this is also a probe where on chromosome number 21, the probes are usually it should be 2s in number, but here it is 3. So it says that there it is. It is a Down syndrome. This is how a FISH report looks for a Down syndrome. Now coming back to the microarray. So microarray can equally play a role in to replace karyotyping in one context, and also to do to check for multiple duplications, translocations, or multiple deletions that are happening in the chromosome regions. So whenever there is so if it is a pediatric setup, right, and if a child is coming with the multiple unexplained learning difficulties or autistic behavior, so in that case the first line of test would be microarray, just to rule out if there is any chromosomal abnormality, so basically structural abnormality, what we were looking for in this case. But what is the role of microarray in prenatal testings? So, when I talk about prenatal testing, any congenital abnormalities that are seen, any soft markers that are seen, more than one soft markers that are seen in the ultrasound, directly it is said to go for a microarray. So there are multiple guidelines which says the first line of test for prenatal diagnostic testing is microarray, because microarray will also give you a picture of number of chromosomes that are present. So it will also cover down. So basically the trisomies and the sex aneuploidies will be covered in microarray, because it will give you a rare view about it, and also it will look into a deeper of it, like what exactly the deletions and duplications are. So even if you are going for a prenatal cases, and if a fetal medicine experts, if they are doing if they're getting the amniocentesis or CVS samples, so the best part is the directly order QFPCR or QFPCR and microarray, because this is the first line of test and it will cover everything. So this is a case in which 14-week fetus with cystic hygromas, hydrops, and increased NT was presented. So in that case, because as I mentioned, first of all, 14 weeks. Second, there were more than one soft markers were present. So obviously, the screening would have been done, but then this patient has come to us for a fetal medicine setups with the saying that there is a 14-week fetus with all these soft markers. So we did a microarray on this patient and we found out that there was a trisomy 20, again trisomy 21, that was Downs, and we got to know from microarray. So it is not necessary that only karyotyping will only pick the trisomies, even microarray could also pick it up. So ACOG and SMFS guidelines says that for prenatal diagnosis, what is important? Karyotyping, is it really sufficient? Because again, karyotyping won't pick microdeletions and duplications. So it is better that if we go for a microarray. So these were the basic tests which we usually go for the testings. So there are multiple tests also, like QFPCR, microarray, QFPCR, exome sequencing. There are also multiple tests, but depending upon the call of it, what exactly and what test to be ordered, that is what we need to do. So this was all about my presentation. If there are any questions, I would like to take any questions related to the topic or anything.
Hello. Very informative lecture. You have covered topic so well. There are no questions. And as you said, it was a detailed and comprehensive fetal assessment you have covered. And you have covered integrated approach very well. That is screening test and diagnostic test. What we like is the practical approach we given with flow charts, so that what next we have to do. That is very clearly told.
Right, sir.
Yeah. Thank you.
So if just for the अच्छा वो हटा दिया ठीक है, so there was a slide which has exact workflow. So if anybody wants to take a picture of that slide, so you can, because that is again from a research paper only. So it actually tells you what exactly, if it is just a soft marker, single soft marker, multiple soft marker, screening, increased, high risk, low risk, everything is there in this. Yes.
So I just want to know as to how much time after the blood is collected is to be processed in the laboratory for these biochemical markers.
So basically, sir, when we talk about the
To
processing,
be specific about PAP and beta histone.
So basically, sir, it is said that within 48 hours it has to be processed. So usually we get the report, so which is the best way. But then if it is outsourcing also, or if it is traveling, so the window should be somewhere around 3 to 4 days, that you should get the report within 3 to 4 days. So the
Okay.
process that has to be done in the lab, it should be within that 48 hours.
Yeah, so that 48 hours. So can I have the message today that the sample should not be collected on the weekends?
Agreed, I agree. But then if the lab are functional and they are, if the logistics are there, so then I think nowadays labs are more frequent in that they are working on Sundays as well. They worked on they worked in COVID as well. So yeah, so you can see that is your right, because ultimately it's your patient.
No, see, we will be following what the guidelines come from the labs. We don't know what technically is happening
Definitely,
there.
sir. Definitely. That's what I'm
That's why
saying.
this
You
question.
ask them. You ask them 100 times. Ki if I'm giving sample on Saturday evening, whether it will be processed and whether I'll get report or not. Because at times it happens. Even in the labs also, by the time sample reaches, it get hemolyzed.
Okay, that's part one of the question. The
Yes.
part two is, who decides after having soft markers which suggest that probably this patient requires diagnostic testing? Who decides, or how do we decide, to be more specific, whether it's a karyotyping, fish, whole genome sequencing, microarray? How do we do that?
So, sir, this is something that which test to order for,
Yeah.
right? So, when I talk about, like, depending upon the soft markers, whatever soft markers we are having, depending upon that, what criteria they are following. So, that is why there is a guideline which says anything, because exome sequencing will be very late in prenatal. There are cases where prenatal exome sequencing are also done, and we have found out the cases also. But then initially when the fetus is in the womb, it will be having more of a chromosomal abnormality, because उस time पे वो बन रहा है, and the chances of getting chromosomal activity is higher as compared to the gene activities. So, if it is a IUGR case, polyhydromas hai, polycystics hai, so then I would say, okay, there is no point in going for microarray, go for a exome sequencing, because I will look for PKD, polycystic kidneys, because I have those criteria in it. So, depending upon what are the findings, and then the number of counselors are there to help you out, multiple geneticists are there. You can anytime reach out to anybody if there is any confusion regarding what test to order, because I understand these tests are not something which everybody can afford. So this is something we are having the battle. Everybody is fighting the same battle in a different way. So I would say whatever indications, be very specific. Whatever you are writing, you don't miss out on anything. Take opinion. Okay, fine. This is what I am suspecting. Beyond downs, is there a chance कि कुछ और हो सकता है? So that is what we have to look into. So now, which I presented a case where it was like it was more than 3 biomarkers, right? Soft markers. So I would have easily gone for a karyotyping, but why would I want to miss it? What if कुछ नया deletion हो गया उस बच्चे में and I would have missed out, and karyotyping comes out to be positive? Oh, sorry, negative. So then what? Yeah. So this is how. So exactly, the clinical implication is very important when it comes to order a test.
Thanks for this.
Can I have a comment on this particular discussion? Yeah, it's a very valid point, Raju, you have brought in, because see what happened. Solapur has a main problem of air connectivity. So what used to happen, we used to sometimes send the person, when you stood the amnio, I used to send the person to Mumbai, taking that sample, avoiding all these problems. But when courier people started saying that we can transport it within one day, we started believing that. But once I lost one sample, when it was taken on Monday, slit reached to Prochi Madan in Jaslok on Thursday, and it was contaminated. And he was my lab technician's wife. You know, it happens, and that's why we have to take into consideration. It all depends on the, what I can say, the activeness of that particular person who is giving you service. Nowadays, the samples from my center go to Chennai. But I will tell you, those people are so active that as soon as I collect the sample, within 1 hour person comes to receive it, and they see that it reaches in time to that particular laboratory. So we never lost any sample per se in recent years. But those days were there. That time even the courier services were not active, and we have to take into consideration. Not only that, but also there are many other factors one need to know, especially all those youngsters. Like suppose patient has got PV bleeding, suppose she has taken recent SCG actually for the support. All those factors need to be taken into consideration whenever we are collecting the sample for screen positive. And about the second part, which is again very very important, it all depends on the for what indication. If it is a routine screening, naturally we have a choice of geneticists, but quite often the clinicians can decide what actually it is. Nowadays we can screen everything for every condition, and we can do the good diagnosis of any given condition. And for that we'll have to see that our geneticist is in very much touch with you. For example, right now, whoever I am contacting last actually 2 3 years, I send a WhatsApp and within 5 minutes I get a reply. So I know what actually I need to know. Not only the taste but also the cost, because many of our patients are not very affording. And that time, what we started doing, we started at least doing for the cases where we could not save the baby, we send the DNA storage so that patient gets breathing time of few months by which actually they can decide whether they want to go for the further testing. And that is very very important and good actually, the thing which we have well in last few years, by which even the poorest patient can think about that particular option whenever they have these problems of genetic conditions in the family.
Especially in POC cases, it is said that in POC cases, because we'll get the sample only once. So every time whenever you're sending sample for POC, just plus DNA storage, that's it. Because that will be like at least for a year or so, this lab will be, any lab for that fact, will be preserving that sample, and whenever the parents are in that state of mind, financially, emotionally, they can come back and do the testing. Because again, agar if we have to wait again कि दोबारा से pregnancy loss हो फिर हम करें, so there's no point. So yeah, thank you so much.
Next lecture is from Dr. Milind Shah, sir. When I have told organizer that I will not take any lecture or topic, so they said that no, you just introduce Dr. Milind Shah, sir. When I got the slide, I came to know that the organizer had given me the short topic to present. On serious note, Dr. Milind Shah, sir, is the most popular figure not only in Solapur but nationally and internationally also. He has been at the helm of many organizations, including SOGS and Foxy and IMA. He is president at SOGS and IMA, and he is vice president at Foxy. He is founder president at IHRF, and he is president at ISOPUB. He has been invited as faculty in many national and international conferences, and the international conferences where sir has given lectures. These all countries are on in my bucket list of travel. They are almost more than 25 to 30 countries. Then he has many publication to his name, and he has written books like hypertensive disorders in pregnancy and pelvic organ prolapse. And he is work as an editor in journal, and he has also peer reviewer at journal also. And yet he is very humble and very easily approachable. In spite of his busy schedule, whenever he is in Solapur, he hits the gym regularly. I usually meet in today morning only. We have met in the gym only. Over to you, sir.
Thank you very much, Kundan, for all those kind words. At the onset, I must say big thanks to SOBG as well as IAP Solapur branch for this wonderful opportunity, because I have seen this travel of NIPT since years. When the samples used to go to Hong Kong, that time also I had sent certain samples for the NIPT. I'm having the very good experience of this particular test, and I got attracted towards it because of these problems of the connectivity and travel, what Rajiv has told just now. And that's why I thought all that journey is very very important. And I think Alakshita has done my path very easy, because she has covered everything about the screening so well. So we can now definitely think about the further things. Basically, friends, I wanted to have this particular disclaimer because I understood that every city, every state, every particular clinic has certain limitations. So we'll have to design ourselves accordingly whenever we are dealing with the screening or the confirmative test. Because we understand that quite often it is not very easy to avail actually those particular facilities easily or offer those facilities easily to our patients But we'll have to do that very, very carefully and aptly by taking more interest in those particular cases. Because we do understand that suppose that baby with genetic defect is born, you know that what actually is going to happen afterwards in entire life of that particular couple. And that's why we'll have to definitely deal with these particular conditions very, very aptly and actively. And we know that we always say about this evidence based. And what evidence based is? All these labels A, B, C. All of you are the very vibrant actually clinicians. You know about it. But what I prefer actually when sitting in the city of Solapur, especially for this Pathfind, I wanted to tell them that we always believe in these good practice points as well, because we know that we'll have to do actually the things according to our availability, our scenario, and our actually the problems which we face with our patient. When it comes to the screening, we know about this Wilson and Jungner criteria, which are applicable to any disease screening person, same applicable to the NIPT as well. And the principles are: watch what makes a test a screening test, which is to establish diagnosis. It is used to distinguish those who probably have the disorder from those who probably don't have the disorder. A positive screening test must be followed up by definitive diagnostic test, and that is very much applicable to the NIPT also. And it's not the test, it is how you use it that is more important, because as I told you, quite often the scenario changes from case to case, condition to condition. Quite often it could be just a routine screening. Quite often it could be a case of Duchenne's muscular dystrophy, which is X-linked. So all those things we'll have to think accordingly whenever we are dealing with these particular cases. What I'm going to do in this particular presentation is going to add upon certain very good experiences, which will be take-home messages for you as well, whenever you are going to deal with those cases in the future. Good screening test. Again, the PSM book, we always say that it should be a cheap and quick, accurate and reproducible, non-invasive, and have a good statistic profile. But always there is a problem about this positive and negative predictivity values of that particular test, and the sensitivity and specificity, where we always and always get stuck. So that's why I thought I will add these two slides, which are very, very important. This square, which tells about what is true positive, what is false positive, what is false negative, and what is true negative. Because it all actually depends on the sensitivity and specificity of that particular test, as well as the positive and the negative predictive value, which is going to offer us actually certain path while dealing with certain actually decisions in that particular given case. Whenever we say test result, it is positive, we'll have to always think about whether it's really true positive or false positive. And that's why the role comes of positive predictive value. And when we say it about negative, again we'll have to decide whether it's true negative or the false negative on this negative predictive value. And coming reverse way, suppose it is diagnosed, then we'll have to again think about its sensitivity as well as the specificity of that particular condition. And that's how actually the any particular screening criteria works. Now we always and always believe, because as we have limited options in variety of ways, as I told you to starting with this particular lecture, we always and always believe in this particular contingent screening, because where we can have a definitive actually the division. But still I tell you friends that you'll have to always and always believe in your actually the clinical judgment also. I'm going to post certain cases in front of you which will tell you what is the importance of it, because quite often there are certain limitations to certain tests, and suppose we don't go according to our actually the clinical findings which you see in your case, maybe with the help of ultrasound, you may actually get problems which we always see in clinical practice, and the patients they grumble. They say that we have done whatever we needed to do and still we got the baby who is having down. So we'll have to have all that particular soft markers or the measuring accurately the NT, which is never and never actually should not be forgotten. Otherwise, quite often I have seen that many people they believe only serum markers. No, serum marker has only 60% actually chance of detecting that particular case. But suppose we do the combine, definitely the predictivity goes very, very high. We know that 30% of the patients will proceed to the second trimester testing if there is intermediate risk. And more often, actually, nowadays we are getting this particular reports in the city of Solapur. by various laboratories, and that's a very commonly posed question, not only here, many other actually the places also. Recently, when we had a ISPAT meeting at Varanasi, where Lakshita also was there, we always got this particular question from the audience that what actually one need to do. Then accordingly, we'll have to think about these contingents. We can offer them the further testing as well, and then we can go for the further screening test or the further definitive test, because we know that when it comes to the, especially the Down syndrome, there is always and always dilemma. The dilemma also I'm going to tell you in coming few slides. Now, what is this NIPT? There are many terminologies people always get confused with, because NIPT first started for this actually aneuploidies, and they thought that is the only indication, but now it has expanded a lot. But now we can do n number of things with even this non-invasive testing, and that's why this terminology started coming in the literature. NIPD, that is non-invasive prenatal diagnosis, whereby specific genetic disorders also can be diagnosed. Unfortunately, those tests are not available in our country, but I'm very sure when we have such a vibrant laboratories available with us, they are going to come in the India as well for the benefit of our patients. Or NIPS, which is commonly used word by the Pathkind, whereby they say about the non-invasive prenatal sexing. Because X-linked disorders, it's always and always question mark what to be done. Just a story of yesterday's, when we did actually for one of the patients CVS, where there are 2 male babies in the family who has Duchenne's muscular dystrophy. And now when the allele was found and when it was diagnosed with the help of CVS, now question comes, the family is asking what is the sex of the child, and I am now dumb. What actually we should do? Because it's so difficult, and then we have to ask the PCPND department, and they will ask you a number of questions. The patient actually then went to the Dharwad, the nearby district, whereby she went and she told me that they have done again amnio to confirm, because they were thinking there were certain actually the limitations of MTT, the maternal cell contamination. And they said, we wanted to repeat. They repeated, and they again found the allele in that particular actually sample. And now the patient told me, doctor has just told me to terminate the pregnancy. I said, true, but suppose it is like you are a carrier of that particular disease, you are very well and hearty. Previously, you had one child where you had done the pregenital diagnosis, and now actually what decision I should take? And very silently she says that, no, actually doctor has told me to terminate the pregnancy, you take the signal. And I was surprised that how the people must be, our clinicians must be facing this. So all our organizations should take this particular point whenever we are having a dialogue with this NIPT, the appropriate authorities of PCP and DT, that these are the situations where we should have some sort of actually the excuse to declare the sex of that particular child. Now, detecting this cell-free fetal DNA in the maternal serum is the basic thing where we use actually NIPT, and it has gone a long travel. As I told you previously, one of the particular company used to collect the samples, and those samples used to go to Hong Kong. So I remember a story when a doctor came to me where the screen was positive. That time we used to do the triple screen, which was very popular in those days. And we sent the sample for NIPT. The sample went to Hong Kong, and the report came that this particular sample has less than 3% DNA retrieval. We cannot opine. So they said, recollect the sample. Again, the sample was collected. Second time sample went, and again the report came, still the DNA retrieval is not good. Because those days the DNA retrieval technology also not that advanced, whereas now it is available in India also. Nowadays we never get this particular problem per se, though it is there in very, very few cases. The third time sample was sent. By the time the patient was 21 weeks, patient doctor. Now the problem came how to deal with. Suppose if at all this, now the report comes, how I am going to manage with that particular case, and I lost the chance of doing even the amnio also for that particular case because I was just waiting for that. And again third time report came, the DNA retrieval was not optimum. The patient had no actually other option than continuing the pregnancy. Fortunately, that particular baby is on 10th standard. But this is what actually the practical difficulties, what I always wanted to share with all my colleagues as well as all my laboratory friends, because these are the issues one need to think about. Now, it uses the mass parallel sequencing to amplify fetal DNA in order to perform genetic testing. And this amplification has gone a long way. Nowadays, it's very easily possible to diagnose the conditions apart from aneuploidies, the even microdeletions also. Currently reporting out increases in fetal DNA for the chromosome 13, 18 and 21, but it has already expanded a lot whereby we can do that. It has only validated in high-risk women, but again that particular thing has gone off. Now we have realized that we can offer this particular test in various conditions as well, and the result takes around 8 to 10 days. And if positive, as Lakshita told, one need to have definitive diagnosis done by either CVS or the MNO, which is required. And as I told you, still in current actually the days also, less than 1% of the sample will have not enough actual DNA, fetal cell-free DNA to test. Now, let me tell you friend one practical point as well. When you register a particular case of NIPT, many laboratories are offering the definitive diagnosis free of cost. So you'll have to take advantage of that. So accordingly, they have options, whether you can order for only NIPT or NIPT with that particular option. Similar option is available with the Pathfind also, what I heard from them, and we can definitely add that particular advantage. Rather, they have gone little further as well. They have offered free NIPT if the double marker or the quadruple marker is positive. So one can think about if the patient is really at high risk, very advanced age, previous baby affected, we can order for that particular combination, whereby we don't need to counsel again and again the patient for the further testing. Because, you know, whenever we counsel them, they always ask us n number of questions which we need to very patiently answer them. And then only they can decide about that particular fact. It is not only the affluent, but even I will tell you, the poorest patients are quite receivable at that particular point. For example, one particular family comes from Dhotri, and that particular, the old woman, she must be hardly second standard, but she understood her condition very well. The first time they got affected a baby, second time they came for the MNO, we could do that, and then third time also she came and she understood that now she needs a prenatal diagnosis very aptly. So it is that are actually sometimes thinking that probably this poor patient coming from a village may not understand and all those things. No, you offer that and let them take the decision. If they don't understand, that is another part. But offering from our side has to be very, very actually effectively, otherwise quite often it may not actually work as well. 8 to 10% of the screening positive will have a normal fetus as well, and that's why this confirmative test is very, very important. Early diagnosis and termination if the confirmative test is positive. Now, the termination is again a big question mark, which we'll see this after 5 facts about the prenatal screening by cell-free DNA. We know that this particular, the incidence of this particular trisomies, whereby we get this. The most common and threatening is the Down syndrome people think about because it is commonly seen. But there are many actually the sex chromosome differences as well, and also many other genetic disorders, and also the microdeletions and the other actually structural deformities. So all those one need to think about because they suffer a lot in variety of ways, maybe in the form of stature, maybe delayed speech, or the health issues involving puberty or even their cardiac defects as well. It is also important to see that all those patients who have a positive conventional screen, one definitely should go for NIPT. More than 40 years of age, again, it is always and always preferred to go for that particular test because the test is now affordable. It is not that expensive as it was. Previously, we had paid 24,000 for this NIPT. Now it's available at the cost of around 10,000 or more. We need to pass on that benefit. But there are again certain hinges which we'll discuss. Confirm history of the aneuploidy, that is previous pregnancy with affected baby, or when the NT is more than 3.5 mm. So all those cases where we should think about this particular option. The fetal congenital anomalies in ultrasound, which are suggestive, what we call as a soft marker. Increased risk of aneuploidy, including combination of risk indicator, including soft markers, biochemistry, and the maternal age. At risk for male with X-linked disorder, when that particular disorder is confirmed in that particular family, has a very high detection rate, suppose we do it effectively with a good lab, and then one need to think about the advantages of it. It says about detection rate and the false positive rate, whereby you can see, suppose we apply this first trimester screen or integrated screen with your ultrasound actually findings as well as serum markers, you do quad or you do this advanced SIPS as well, whereby we can definitely get more advantage with the NIPT, suppose it is possible to do. And it is a very sophisticated screen, however, there are important limitations also of that particular thing. One, we understood about the getting that cell-free DNA, which is now less than 1%. Previously, actually, it was quite high. They used to quote 35% of the patients, they used to get negative, actually, the retrieval when we used to send the maternal blood for the cell-free DNA. One need to actually definitely think about the diagnostic testing, that is confirmatory testing, whenever screen is positive, because the confined placental mosaicism, where the genetic makeup of the placenta does not represent that of fetus. And this is a very good picture I would like to present in front of you, which tells about the possible explanation for a false positive result present in the 1 to 2% of first trimester placenta, whereby you can see how actually this euploid and the aneuploid cells, they get mixed up, and there is every chance that there is a risk of getting the false positive test. Diagnostic testing is recommended before any irrevocable action in the form of either CVS or the amniocentesis, because of this confined placental mosaicism, fetal mosaicism, or the cases of vanishing twin as well. At late first trimester ultrasound at 11 to 14 weeks may be offered whenever available, or maybe ultrasound at 18 to 20 weeks of gestation, as I told you, to combine actually your clinical findings whenever there is suspicion of having this particular problem of getting affected baby. The 1 to 6% of the women will need a second blood, and almost half to 3/4 will then receive a result. There are technical issues also involved in this particular thing, and whereby you'll have to ask your laboratories very bluntly, or you can say in good way, to understand whether there are any issues related to that. For example, once when I had sent a sample for CVS with actually maternal cell contamination, the geneticist called me, I can see those villi, but whenever we try to separate it, somehow I am finding the same pattern as of maternal actually cells. So I am a bit confused whether that villi are in sufficient quantity or no. I said, good that you have conveyed to me, because then accordingly I can think about the further testing as well. Otherwise, quite often they may actually hurry up in giving certain reports, which will again create more problems in future. So this particular dialogue has to be very transparent, and naturally we offer that particular patient further testing as well in the form of amnio to confirm our findings. And nothing actually need to be emphasized on that geneticist's role is very, very important, because whatever said and done, as a busy OBGYNs, we are so busy with our deliveries, obstetric work, infertility work, and endoscopies. Sometimes we may miss on the certain research advances. So always and always speak with them, and they always and always help you in a good way to get the further actually the light on that particular case. There is a limited evidence about the performance of this cell-free DNA screening in the twin pregnancies or the triplet pregnancy. That also need to be understood. And as I told you, the microdeletions, whenever there are these microdeletions, you can see how it can affect the further fate of that particular baby, and that is also nowadays possible with the help of NIPT. There are arguments for offering cell-free DNA with the microdeletions as well, because cumulatively these disorders are common. The combined at-birth incidence of the 5 commonly offered microdeletion syndromes is approximately 1 in 1,000. And the incidence is independent of the maternal age as well. There are also actually certain other arguments that positive results are inevitable, and no published clinical validation studies are available. But I am very sure that in coming few years, more torch will be thrown on these particular conditions of microdeletions as well. There are no recommended guidelines per se right now about this particular fact. Now, I am going to pose only 2 cases and conclude, because I know all of you want to have a more discussion as well on this particular screening, because there are n number of such scenarios which come in front of you. And like patient goes to one clinic and then comes to your clinic and all those things. For example, I remember recently we had an ultrasound workshop, and one of the faculty was saying, nowadays in Ahmedabad, we don't offer the dual marker or the quadruple marker. We directly offer the NIPT because now it's available in our city for only 7,000. At least we get the result. The question comes, is it a very correct decision to do so? It all depends with big 3 question marks as well. For example, look at this particular woman of 38 years of age. She and her partner were undecided about the self-pay non-invasive testing. Again, there was certain issue about this self-pay means they used to collect the previously sample from the home. And that's how we got a lot of restrictions on NIPT to start with, especially in Mumbai. With the appropriate authority, we had so much discussion because they used to say that, no, we are not going to allow NIPT in city of Mumbai. And we used to say, why? It is available in my city of Solapur. We are doing it. We are filling up that G form and we are doing it. But they said, no, आपको पता नहीं है, दिल्ली में ना वो सैंपल घर में से जाके कलेक्ट करते हैं, कहाँ तो भेजते हैं और सेक्स बताते हैं पेशेंट्स का और पेशेंट्स टर्मिनेट करते हैं. And that's why one need to think about that particular thing also. Nowadays, at least in our state of Maharashtra, we are not asked to fill up the G form for the NIPT, but I learned from the laboratory that they actually ask for it. For the safety, I will always fill up the G form and keep it on my record, but I don't submit it because they don't want it. Unnecessary, I don't want to start with that new tradition, but I know that sometimes they may actually change as well in their policies. So, these cell-free NIPT results are reported first as a low risk, whereas when they did the fetal screen as well, enhanced fetal screen, which is reported 4 days later and screen is positive. Now question comes what to be done because it's a dilemma whereby we were thinking of doing first this screening of with the help of serum marker and the ultrasound markers and then NIPT where the patient has come with both tests in their hand and now they have this particular scenario. Now question comes how to go ahead. Now you refer to geneticists to discuss diagnostic testing, you reassure the patient, offer 18 to 22 weeks scan. You repeat this cell-free DNA, NIPT, you order quad screening or none of the above. Can anyone answer this particular question? Any of the clinicians who are doing this test routinely? Yes? The bottom line is, friends, all of us are the advocacy. We need to tell them that if NIPT is being done as a primary screening, do not actually go for the further testing, which will create more confusion. And then finally what happens, then we have to land up with the confirmative test in the form of invasive testing. And that's why this is a very important, good actually message. That's why I told you, we need to speak with our geneticist about this particular scenario quite often. Now another scenario I will tell you, the 29-year-old woman with an NT of 4.4 at 12.5 weeks of gestation, you offer NIPT, she accepts, NIPT results are normal, she is now 14 plus 2 weeks, you offer genetic counsel and she accepts. Now what you will like to offer for her? Sorry, how I can go behind? Yes, the chromosomal microarray, genetic testing for the other single genetic conditions, detailed ultrasound, fetal echocardiogram or all of the above. I think Sumit is very much here, so he can put a good light on that, yes. What we should do in such scenario? Yes, anyone? Yes, that seniority always counts, all of the above, because we know again a dilemma whereby we need to think about a lot and we'll have to go with whatever actually we can do for the particular case when there is some sort of suspicion of having the affected baby. Now this particular scenario, a patient came from Akkalkot. The father works for the mutt of that particular Akkalkot Swami, and we got the screen positive, NIPT positive, we offered them the invasive testing. The patient denied for the further workup. And then my question was how actually I should go ahead. What I need to do for that particular case, because this situation never came in front of me, whereby I went halfway and now patient declines for the further testing. She says, no, let it be, Swami bhaktil tya balacha kai vilte, but mala nahi karaycha testing. What is one need to do is the documentation in the case paper. We have to write down very, very aptly that we have advised them and all those things. And it is not just shrugging off your responsibility, but also advising them the good genetic sonogram also. because that also can put a lot of light actually in that particular condition. So one need to actually think about such scenarios also, which always come in our practice. Now, whenever we say termination, can I have sound to this particular video? थोड़ा वॉल्यूम बढ़ाओ.
Identify Down syndrome in the womb, and those pregnancies will just be terminated. It's hard for me to sit here and say those words. I completely understand that the people pushing this particular final solution are saying that people like me should not exist. Seriously, I have a great life. I have lectured at universities. I have been to the White House twice, and I didn't have to jump the fence either time. Seriously, I don't feel I should have to justify my existence. On a deeply personal note, I cannot tell you how much it means to me that my extra chromosome might lead to the answer to Alzheimer's.
Yeah, I will share this particular video on various WhatsApp groups so that all the pediatricians as well as the OBGYNs will go into the detail of this particular video. But what it tells us, that yes, it is an individual right as well, and whenever we say about this human rights and all other things, we'll have to think about it. Because this particular case of Pakkalkot told me, similarly I got another case who was 43 years old professor who conceived after long standing infertility and screen was positive. You know what actually the answer got from her, that she said, "Doctor, असू देत, मला कसंही वेडं वाकडं मूल झालं तरी चालेल, पण मला मूल पाहिजे का तर मी आई होणार आहे." You know, it told me that yes, we should not immediately hurry for the termination, because we know there are so many actually variations, the downs also. And that's why when this conference of downs, what they say about in this particular video held up, all those actually the girls and boys were there who were affected by Down syndrome. One need to take, we need to think about that particular aspects as well. It's really very, very necessary to make room to leave an empty space in order to allow correct things to arrive in your life, what actually these lessons we need to take home. Thank you very much, friends from the patient listening. It was really wonderful having you all here for this particular talk. Thank you.
Thank you so much, Dr. Milind Shah sir, who is a teacher, mentor and academician, and also a very national and international SOGS person, because we have seen that Solapur is so famous because whenever we meet in conferences, everybody knows about Solapur and Dr. Milind Shah sir. As Dr. Kundan said, to say about Milind Shah is like presenting a small topic. And thank you for this wonderful lecture. All practical cases, practical approaches and issues very well covered. And the last and very touching, and it's worth to say that the lecture by that Down syndrome man, and we would definitely like to hear that video again. Sure. Thank you, sir.
Thank you very much. Thank you.
Now for the next lecture, I would like to introduce Dr. Anna Saheb Lokhande, who is a consultant pediatrician at Navjeevan Hospital, Solapur, Director, Stepping Stone Childcare Private Limited, Executive Member of Solapur Academy of Pediatrics, Joint Organizing Secretary at Maha Pedicon, Honorary Consultant Pediatrician at Police Rugnalaya Solapur, Railway Hospital, Kendriya Vidya School, District Trainer for Neonatal Resuscitation at DTC, First prize for case presentation in Maha Pedicon 2015, and trained in a various pediatric clinical modules of IAP.
And he will be next coming president of Solapur Academy of Pediatrics.
Thank you, madam, for your kind introduction. I thank you to Solapur Obstetric Association and IIP Solapur providing me the platform to present my topic on newborn screening. Respected senior obstetricians, my teachers, senior pediatricians, and my dear colleagues. My today's topic is newborn screening for genetic disorder. Overview for this topic is, I will introduce the topic, what is the need of screening, whom to screen, when to screen, how to screen, what are various methods of screening, what next, what difficulties, what is Indian screening program and current scenario, and what is hope, and finally I will end up with my session. So neonatal screening is a public health problem and it is integral part of our newborn care. Screening of babies with potentially treatable conditions not clinically evident before newborn period. So what is newborn screening or neonatal screening? Screening is application of medical tests prior to development of the disease. So that's why we are applying it prior to the developing of the disease and we are treating the condition and changing the course of the disease. So what is the aim in newborn screening? We have to catch them early, identify them before the morbidity set in. So how this is possible? So there is development of various technologies in the field of molecular biology, biochemistry, detects disorder before clinical symptoms starts. Screening should be initiated for the disorders which are relatively more prevalent, for which definitive and effective treatment is available. Screening tests are tools to detect the disorder, but the confirmatory test is necessary to start the treatment. So most of we are today dealing with the specific genetic disorder. These are the inborn errors of metabolism and they have serious clinical consequences. They can cause irreversible damage to the brain, causing mental retardation, physical disability, and neurological damage, even fatality. The aim of neonatal screening is to detect the conditions before onset of the symptoms so as to treatment can be started as early as possible and to prevent the damage to the various organs. Need of the screening in India, we have high birth rate. NBS is not a neonatal screening is not a routine practice. There are few conditions which are genetically determined, which have high incidence like congenital hypothyroidism, congenital CAH, G6PD deficiency, and also along with that we have high rate of consanguinity and endogamy, that is marriages between the similar group. As lack of awareness and lack of adequate diagnostic facilities, there are increasing numbers of these morbidity and mortalities in early neonatal period. So this is little bit data, recent studies on prevalence of common IEM, inborn error of submarine in India. The data is from 2004 to 2019. So various disorders they have shown in particular congenital hypothyroidism, congenital adrenal hyperplasia, glucose 6-phosphate dehydrogenase deficiency. So that data persistently showing these cases are persistently there. So that is the necessity to screen at least these diseases which are very prevalent. Infant mortality rate, here we can see it is on the top in under 5 mortality. So along with the infections and birth asphyxia, there are patients which are dying because of lack of screening. How it helps? Neonatal screening, it helps in identification, early intervention, it reduces mortality, morbidity, it also allows a particular family for its planning. And thus NBS helps in reducing the preventable developmental delay, disability, mortality, morbidity during the infancy and childhood. The outcome of better quality of life can be given if the screening is done in a proper time. So internationally also, this IEM has been celebrated So June 28 celebrates Dr. Robert Guthrie, who performed the first test on the phenylketonuria. And the first International Neonatal Screening Day, it was celebrated on the 28th of June 2021. We are celebrating this Neonatal Screening Day especially for life-changing benefits of early detection of disease and the opportunity to offer in terms of early access to the treatment. What diseases can be screened off? Now the Wilson and Junger criteria for diseases selection in neonatal screening. The test where we are applying that should have important health problem for the community. The natural history of the condition should be well understood. It should be detectable at an early age. Treatment of early stage should be beneficial for the patient. There should be suitable test which should be devised for early detection of the disease. The test should be acceptable. Intervals for repeating the test should be available if it is indeterminate. Adequate health services provision should be made for the extra clinical workload increasing from the screening. The risk, both physical and psychological, should be less than the benefits. And after all, the cost is very important. The cost should be balanced against the benefits. So these are the criteria given by the Wilson and Junger to selecting the diseases. So there are few categories where the screening is important. According to the IAP, Indian Academy of Pediatrics, they have made 3 categories. Category 1, they want to offer the newborn screening in congenital hypothyroidism, congenital hearing, that is must for all the newborns. Screening of CH, G6PD deficiency in a phased manner. G6PD screening should be done in a northern state of the country. Screening for the sickle cell disease and other hemoglobinopathies according to the high incidence in the particular pocket. So there is another category which is having high risk screening. Screening for the following disorders is where the high risk population, where the consanguinity, previous children with unexplained intellectual disability, seizure disorder, previous unexplained sibling death, critically ill neonates, newborn, children with symptoms, signs, investigation suggestive of inborn error of metabolism. Most commonly, these conditions include PKU, homocystinuria, alkaptonuria, galactosemia, sickle cell disease, hemoglobinopathy, cystic fibrosis, biotinase deficiency, maple syrup disease, medium chain acyl-CoA dehydrogenase deficiency, tyrosinemia, and fatty oxidation defects. Category C to be offered to the well-to-do families, especially in urban settings where the facilities for sending sample and laboratory they are available. What diseases can be screened for? Genetic disorder with serious clinical consequences. If the left undiagnosed and untreated, this disorder can cause irreversible mental retardation ranging from mild to severe physical disability and neurological damage and even fatality. So newborn screening is done by hearing test, pulse oximetry test, blood test. So what is inborn error of metabolism? It is a diverse heterogeneous group of hereditary biochemical disorders with versatile clinical manifestation, mainly children. That we know the pathophysiology of the IM, that A product is converted into B, B is converted into C, and there are enzymes required in between. And if there is any absence of enzyme particularly, then the B product will be directly converted to the D, and that can be harmful to the body, and it will damage to the particular organ. So these babies are usually normal at birth. There is a rapid progressive course of the disease. In the NICU, the babies present with the septic screen negative, they are septic mimics, we say that, non-specific symptoms, but all the septic screen is negative. And we referred it as a metabolic distress. So there are the few incidences. Inborn error of metabolism, where to suspect prenatal consanguinity, positive family history of similar illness, history of clinical deterioration in previously normal neonate, symptoms onset few days after feeding, refusal to feed, vomiting, lethargy, hypotonia, seizures, persistent vomiting, hypoglycemia, metabolic acidosis, developmental delay, regression. These are the common symptoms for included in for almost all inborn errors of metabolism, dysmorphic features. Signs and symptoms, as we have seen already. Problems with newborn screening in India. Time of sampling traditionally 48 to 72 hours. Tendency for early discharge from the PNC. Home deliveries. Not considered as a healthcare priority. Not considered as a cost-effective measure. Screening is non-availability and non-availability and cost of treatment, feasibility, huge population, transport of sample, and paucity of laboratories and trained personnel. These are the factors coming between this neonatal screening. So questions of neonatal screening in India: need for the test, whether the test is really needed, cost, turnaround test, which child to test, when, where, how. These are the all questions. So now I am taking few common clinical entities where we are getting the more incidence. So most commonly we have to deal with the congenital hypothyroidism, most common preventable cause of mental retardation. Incidence is 1 into 1,000 to 1 into 1,500 live births. Early detection and treatment of CH through the neonatal screening prevents the irreversible neurodevelopmental delay and optimize the developmental outcome. Either cord blood or postnatal sample after 48 to 72 hours is collected for the screening. Second strategy for the screening or preterm neonates or neonate is ill, admitted in the NICU, is you can after 7 days you can collect the sample. So TSH in the cord blood sample should be taken, or if the level is above 20 milli international unit, the newborn should be retested for the serum T4 and T3, free T4, T3, and its values are accordingly, we have to start the treatment. Preferably, if that values they are not clearly conclusive, then we have to repeat the test after 2 weeks. Most of the congenital hypothyroid cases, they are because of dysgenesis. So we need to find out that for the etiological diagnosis by doing technetium thyroid scan or ultrasound. Okay, primary thyroid hormone screen is more sensitive and specific for the diagnosis of congenital hypothyroidism compared to T4 screening. So primary TSH screening may fail to detect central CH, but the TSH measured from the dried blood spot expressed whole units is very important in the screening. So we have to offer the treatment to the patient as early as possible whenever we detect the derangement in the TSH levels. We start the initial treatment with the thyroxine. So second clinical entity is congenital adrenal hyperplasia. Incidence of classic CH is 1 in 14,000. Depending upon the severity and limiting enzyme deficiency, there are salt wasting, simple virilizing, and non-classic CH. So complete deficiency of the enzyme 17-hydroxylase and there is a complete block of synthesis of glucocorticoids and mineralocorticoids. Girls present with virilization at birth and boys are diagnosed late during their salt losing crisis, 5 to 15 days of life, or not diagnosed at all, resulting in the neonatal death due to the wrong diagnosis like sepsis or hypoglycemia. Simple virilizing CH is milder variety. There is also another classic CH, non-classic CH, where the mild form of 10-hydroxylase deficiency, also called as late onset CH. How to diagnose CH is acetase stimulation test. Ideal time of measurement 17 OHP is before 8 am. Basal value of 17 OHP and cortisol should be measured. Repeat values can be measured after 60 minutes. Results are in classical CH, both basal more than 2000 nanogram per deciliter and stimulated 5000 to 10,000 will be elevated. In a non-classical or normal or mild elevation of BSL with high stimulated levels. There are also another tests for confirming the diagnosis, molecular genetic screening, etc. So in treatment part, glucocorticoid supplementation to start with mineralocorticoids, and we have to maintain all the patient's blood pressure and mineral corticoid and glucocorticoid activity by giving the maintenance therapy. G6PD, glucose 6-phosphate dehydrogenase deficiency, is another one of the most important entity, incidence ranging from 2 to 27% in a different communities. Most common human enzyme deficiency among the affecting more than 400 million people worldwide. Presently, they constitute the 4th commonest cause in neonatal mortality in urban areas in India. Hemolysis is triggered by various factors that we know: bacterial, viral infections, sulfonamides, chemicals like naphthalene, henna. All these factors, they trigger the hemolysis. Newborn screening program for G6PD, the test known as modified Parmesan ring test, involving the simple heel prick in the first 48 hours of life, can be used in the neonates. The positive screen is defined as the disc with the absence of bluish discoloration less than 5.5 millimeter. Early detection and prevention of hemolytic disease by avoiding the triggers is the only cure for the disease. Hence, the neonatal screening program for G6PD deficiency is warranted and increased availability of funds for the health sector under the NRHM. MCAD deficiency, commonest mitochondrial fatty acid oxidation disorder. Exact incidence and prevalence, though it is not known in Indian subcontinent, it is the leading cause of unexplained death and rarely reported in Asian and Indian population. Is a mutation occurs and in the medium chain acyl dehydrogenase ACDAM gene. When undiagnosed in the neonatal period, affected patient generally manifest within the 3 months to 5 years with episodes of acute illness, refusal to feed, dull activity, and abnormal movements of limbs precipitated by prolonged fasting more than 12 to 16 hours. How to manage? Tandem mass spectrometry revealed elevated levels of medium chain acyl carnitase C6 and C8, octyl carnitine, and significant elevated ratio of C8 and C10, which is specific to MCAD. It is usually diagnosed by TMS during the newborn screening program. So mainstay of treatment is avoiding the fasting more than 12 hours and frequent feeding. Catabolic stress should be avoided. There is no clear-cut recommendation of carnitine, but carnitine supplementation can be given. The prognosis is excellent for those who survive metabolic crisis period without brain damage. PKU, this is the another most important disorder, deficiency of phenylalanine hydroxylase, that is responsible for processing the essential amino acids phenylalanine and leads to the elevated level of phenylalanine and phenylalanine metabolites. It is worldwide prevalence around 6 people per 1 lakh births. Newborn symptoms are usually absent, may be abnormally drowsy, and sepsis-like presentation is there. Children, they present with seizure, nausea, vomiting, hyperactivity, aggressive behavior. So, in mother also, PKU in mother and pregnancy, elevated levels of phenylalanine, it is a teratogenic, spontaneous miscarriages, IUGR, microcephaly, these are the presentation. So, it is necessary to do newborn screening. Phenylalanine level dried blood spot specimen at least 12 hours after birth. Tests performed are Guthrie inhibition test, McCannon-Robbins fluorometric test. The blood specimens for screening should be obtained. The management of PKU, carrier status identified, at-risk family members with positive family history, and treatment is offered only is the diet restricted with phenylalanine starting in a few weeks of life. Infants with PKU should be breastfed along with the special formula which is phenylalanine free. Some congenital heart diseases, they can be screened with the some critical congenital heart diseases, timing after 24 hours by SpO2 monitoring in the 4 limbs, and the sensitivity and specificity is very good for this test. Some hemoglobin disorders, as hemoglobin disorders are considered to be serious health problem by WHO. In India, the carrier frequency of beta thalassemia varies from 1 to 17%, means 3.3%. It is estimated that about 10,000 babies affected with the beta thalassemia are born every year. So, after elaborating few disorders, now when to test? Newborn screening is done in between 2nd to 7th day of life, and sick and premature babies 7th day with repeat test at 1 month. Now steps to collect the sample. We have to take all aseptic precautions, wear the gloves, position the baby, written consent, whatever all the counseling before the testing should be done. Position of the baby with foot down, this will help the blood flow easily. Warm site with the soft cloth, moisten with the warm water up to 41 degrees centigrade for 3 to 5 minutes. Clean site with alcohol preparation, allow it to dry, air dry for 30 seconds. Then puncture the site at the depth of less than 2 mm using sterile lancet. Allow the large blood droplet to form without excessive squeezing. Touch the filter paper to the blood. Allow blood to soak through completely in each circle. Total saturation of the circle must be evident when the paper is viewed on both sides, but do not apply blood on both sides. Then place filter paper with a horizontal clean dry surface, air dry for at least 3 hours. Keep away from direct sunlight and bags. Do not allow blood spot to come into contact with any surface or each other. This procedure is shown in the figure. So this is the complete, we have to fill up that particular circle on the filter paper. So there is a panel given by the laboratories where we can send neonatal screening panel 1 to all this about the disorders which are commonly present in the neonatal period. TSH, we can send TSH, G6PD and 17 OHP. This is panel number 1. Turnaround time test report 3rd working day. The specimen all we know that is the heel prick by. Neonatal screen panel number 2. To above all phenylalanine is added, the 5th working day we will get the result, we can start the treatment. Neonatal screening panel 3, TSH, G6PD, 17 OHP, phenylalanine, cystic fibrosis, galactosemia, biotinidase, the 5th working day we will get the result. And the panel 4, more than 42 parameters they are checked, we will get the result on the 5th working day. So most importantly, we have to do neonatal screening in above condition where the treatment is available, the CAH, G6PD deficiency, congenital hypothyroidism, hemoglobinopathies, cystic fibrosis and galactosemia. These are the recommendations by Indian Academy of Pediatrics. What is the impact of all these things, testing and outcome after knowing that the baby is having screening positive? So early diagnosis allows genetic counseling of the families in the most of the cases, the option of prenatal diagnosis in subsequent pregnancies. Accurate result reduces the parental anxiety and long-term detrimental effects. Universal newborn screening needs to be introduced in a phase in our country. Screening should be done after 2 days before 7 days. So positive screening test needs to be followed with parental counseling and confirmation of the disease. So after this, what are the challenges in developing the newborn screening program in India? There is a ABCD of these challenges. So A is awareness and attitude anxiety. We have a lot of we are not having awareness about these genetic disorders. The lack of there is no enough education to these parents or the people about the IM. They don't have attitude to expend the money and continue the treatment for long period. So budget is another problem for the government also. Screening program in India currently not funded by federal government or state government. But few of the centers in Delhi, Mumbai, Bangalore, they are offering the newborn screening services in affordable prices. C is current practices, costing, counseling, consent. Current practices in the last few years include many neonatologists doing some screening for the babies under their care with no national guidelines to follow. The cost means which includes cost of testing, cost of retesting, confirmatory tests, ongoing need for the treatment plus cost of manpower also. The disease burden, detailed reporting, dietary advice, drugs are involved. India is a single country of multiple cultures and genetic traits. The importance of drug therapy needs to be understood by pediatricians, families and the affected children, people in the government, and these drugs should be subsidized. Efficiency, evaluation and detailed diagnosis. Efficiency starts from the education of the people involved in the sample collection, and certain diseases may require enzymes to be challenged by giving adequate milk feeds and after starting, you have to repeat the test. For example, urea cycle defects, galactosemia. And follow-up services, they are very important. Future perspectives, we have to research for that, and family therapy. Success of the program involves adequate follow-up. Follow-up of the services involve adequate explanation to the parents about the financial constraint, the future perspectives, to allay their fears. Genetic counseling and geneticists. The availability of the geneticists is also important factor in India, where the consanguineous marriages are more. Home therapy and homeotherapy. Nowadays, so much is jargon about these mixed therapies and mixed pathies. Parental belief, they think that home therapy and alternative medicines like homeopathy can dictate the success or failure of the program. Once the disease is diagnosed, many parents in the India cannot imagine some disease and need dietary restrictions and lifelong supplementations of drug, which automatically lead them with the special pressure to seek the alternative therapies. For example, many parents with the child of congenital hypothyroidism may start seeking some dietary modification to cure the hypothyroidism rather than giving thyroxine. So what is Indian scenario? In India, Goa government, Kerala government, West Bengal, Gujarat, they all have started the newborn screening program. But in Goa, after starting in 2008, the program has been aborted in 2013, maybe because of the various difficulties what we have discussed earlier. In India, these are the most common diseases where screening is available. Introduction of NBS in our country, the WHO has often recommended genetic services to be introduced in countries with IMR less than 50. Indian Academy of Pediatrics and National Neonatal Forum have a major role to play, advocate for NBS and success of the program. National-wide program called Rashtriya Bal Swasthya Karyakram to screen for the conditions like hypothyroidism, mental retardation, speech and hearing disabilities. So newborn screening is a limited program at government, pediatric age group. They have including in the Rashtriya Bal Swasthya Karyakram introduced for early detection and treatment for few diseases, but no nationwide newborn screening program yet which can detect these disorders early and prevent the morbidities. What do we have? So I appeal to everyone to our colleagues that we need to think about all the neonatal screening where though the diseases are rare, but definitely today I can say the pregnancy is investment because mother is investing her 9 months, mother is working, she is investing her job, and every child is precious. So we have to give best of the best to the parents. With everybody's patient listening, I thank you all. I thank you to the organizing team. Thank you once again.
Excellent talk. I think you have given the tagline of the CME, catch them early. Topic is so vast, but you have covered it very well. And with all practical points, along with the treatments also, you have covered everything. Any questions?
So I have tried to not to delay, and I hastened my speed and tried to cover it within short time.
Very well covered.
Thank you, sir.
Thank you very much.
Thank you, sir. I now request our chairperson to felicitate the speakers. Dr. Milind Shah, sir. Dr. Rakshita Chavan. And Dr. Lokhande, sir. I request President SOGS, Dr. Virkar sir, to felicitate our chairpersons, Dr. Meenal and Dr. Kundan. As we all know that our SOGS team 22-23 has recently been awarded the Best Society Prize at AMOX Conference Nashik. It is indeed a very proud moment for all of us. In the year 22-23, under the able leadership of Dr. Anjali Jamma Madam, our society had a feast of academic, non-academic as well as social activities. The job done by the whole team, Dr. Jamma Madam, Dr. Archana, Dr. Supriya and Dr. Monica is really commendable. So, to felicitate and honor their winning team, I request Dr. Sardesai Madam and Dr. Munot Madam to please come forward. I request Anjali Jamma Madam and the team to please come.
Thank you all. It gives me a pleasure to propose the vote of thanks. I thank the team SOGS 22-23 for presence for the celebration of award. I would like to thank today's speakers Lakshita Man, Milind Shah sir and Anna Lokhande for their wonderful lectures. I thank chairpersons Dr. Meenal, Dr. Kundan for chairing this session nicely. I thank audience who came in large numbers. I would like to thank Team Pathkind Labs. And now I invite all for the delicious dinner.
Hello. I want to make one announcement. We are going to conduct MahaNeoCon, that is 19th annual conference of NNF, this 1st and 2nd July. And on that pre-workshop is there on 30th June. There are two workshops. One is nurses workshop, that is for neonatal nurses screening. So you can send your staffs so they can be well trained for nursing. And second is advanced NRP. That can be, obstetrician can also join for this advanced NRP workshop. That is on 30th June.
There is also one announcement. Friends, we are going to start the ISOPAP Solapur chapter as well. These are the forms for life membership. It is a group of gynecologists, neonatologists, pediatricians, as well as social scientists. So my request to all the OBGYNs present here, as well as the pediatrician, to please collect these forms, whoever wants to become a member of ISOPAP. It's very easy to become a life member of ISOPAP, and accordingly we'll then very soon inaugurate a chapter of Solapur for the ISOPAP. Yeah. Thank you very much.